Belinda, welcome to another week. It feels like only yesterday that I was hearing that music and we were recording. How the time flies by, huh?
When you're having fun. I must say, Paddy, I love our tune. I just love it.
Yeah, I
Isn't it
think
great?
our producer did a good job.
An editor. Yeah.
Our team.
Yeah, love it.
I do love
In the studio.
Yeah, in the studio. I do love when people tell me their perception of what they think, how this happens, and like
gosh.
the fact that they think that we work full time at this, at like the podcast and social media. Like
But that's the
amazes
thing.
me.
We have to cover this as well, Paddy, because we have massive full-time jobs.
Yeah, like
as well as this.
So like you have a full time home
Mental.
Yes. Like multiple humans that you were caring for.
Yeah.
I work one full-time job, another job.
And a part-time, yeah.
And a part-time job. And then I have 2 different Instagrams. Go follow the Irish Paddy as well if you're not. On my main page, which is a dose of Paddy. To follow it.
Oh, well, you can also follow at GLP1 Insights.
All right. And then on TikTok as well. So like, so this is when we touched on this last week when we were talking, but like about the volume of messages we get from people looking for support, and it's just not feasible. Like in the early days, I always reply to everyone, always reply to everyone. But it's, with the volume of one there and the complexities of the questions that we're getting asked, as we were saying last week,
it's too hard.
It's just not. If this was a full-time job for me, absolutely. I could lean in and reply to everybody and, guide them on, hey, go to a doctor here, do a dietitian here, whatever. But just with our full-time lives that we have, it's, yeah.
But do you know what they say, Paddy?
Yeah.
If you want something done, ask a busy person.
Yeah, this thing. Yeah. So, how have things been since we last spoke?
Brilliant. It's been so long ago, Paddy.
Yeah. How has the week been for you?
I've had the best week ever.
Really?
Nothing stands out.
Yeah, no, nothing stands out. Of course, I'm away on holidays now, so I am.
That's correct.
Yeah.
And I'm obviously back because
you were back last week. Yeah, but I'm currently in Mallorca. Which is a lovely holiday.
Yeah. How is it?
It's lovely to be away. So it is. Yeah.
Sunny?
Very. The forecast is good.
But we're so looking forward to this week's guest, aren't we? And I don't think we've told anyone up to now.
We said it at the end of last week's podcast.
Oh,
yeah.
did we?
Yeah,
oh, yes,
we did.
Of course we did.
But of course, that was a week ago. I don't expect you to remember.
Yeah.
Okay.
Yeah.
Context here, folks, is because I'm going to end holidays and stuff. We're recording the intro for this podcast literally 5 minutes after we recorded last week's podcast. So we're coming clean.
Yeah.
But
he's not anywhere. He's in his front room.
Yeah, but I am actually on holidays. But I am actually still in Ireland whilst we record this intro. I did allude to a weight check-in.
Yes, you did. And I didn't have to wait. So this is amazing. Go for it.
Our listeners
You did it, didn't you?
I hit 100 pounds today.
Fucker. Paddy, I'm so jealous. I'm just delighted for you. I will say that, but I'm extremely jealous.
Like,
congratulations, mate.
Like,
honestly.
100
pounds. Fuck. 7 stone 2 pounds.
And Belinda, I only weighed myself before we come in to record the podcast. So I literally only.
That was middle of the day.
Yeah,
What did you do that for?
Because I thought, well, I want to give an update to people on how things are going. I literally only record, I literally only weighed myself before I started talking to you.
4 o'clock. That was 2 hours ago.
Yeah. So it hasn't fully sunk in. I have not sat with it fully yet. The fact that I have actually.
No, because you've jumped right into this.
Yes.
So yeah,
And like I
give
had literally
yourself-
just shared, I had literally just shared a post about, oh, I've hit, my 7 stone loss because I was delighted with that. I hit it like only a day ago.
and now you got to £100.
£100.
Can I just ask you a quick question, Paddy?
Yeah.
Say if you weren't on Manjaro and you had lost this weight through slimming rooms,
Yeah.
what would you have done now after hitting £100? What would be your first thought?
Probably to go and get a Chinese.
Yeah.
Honestly,
has
probably.
that crossed your
Not
mind?
at all. No, not a hope.
Yeah.
No.
Brilliant.
Um.
And that in itself is a win as well, isn't it?
Oh, massively.
Yeah. Yeah.
So like you are the first person to know that I've hit my
Apart from
£100.
all the hundreds of people listening to us as well.
No, but like they won't hear till next week.
Yeah.
Like, you know what I mean? Yeah.
Are you going to share that on social media, or have you already done it now?
No, I haven't shared it. So
Right,
by the time this podcast will have come out and people are listening, I will probably have shared it on social media
Yeah.
by then. Because
Yeah.
I want to an update, because this is it.
Proper update.
This is something that is meaningful to me. So this.
Yeah.
This is as I said in last week's podcast, this is my first big milestone that I've had for years. And the thing is, like when we spoke 2 weeks ago, maybe it was, or 3 weeks ago, about, oh my God, wouldn't it be great if I hit the £100 for my birthday?
Yeah.
It's my birthday in
and
2 days.
happened before. Yeah.
2 days.
Yeah.
And the mental thing is, Belinda, I have hit it to the ounce. To the ounce.
Your body's wild, isn't it?
I started my journey at 336.4 pounds. 336.4 pounds.
Wow.
Today I am 236.4 pounds.
That's wild. To the ounce.
To the ounce.
That's crazy.
Yeah. I might be misremembering the point there, but it is literally to the point of what it was when I started. Like,
And
like
you
100% exactly.
still have so much left in your journey.
I do. Are you calling me
Yeah.
fat?
No.
Are you?
No, I'm
Oh
not.
my God. You bitch. What are you saying? I've so much left in my journey. Oh my. Do you know, we did this last week too, folks. But you know what? That is it. We're done, Belinda. Fuck off, you old bitch. I've so much left in my journey.
No, I didn't mean it like
Wow.
that. Stop now. I'm not that bitch. I'm not that girl, right? What I meant is...
Lindsay Lohan.
Yeah. What I meant was, you still can lose so much.
Well,
you haven't hit any kind of set point.
Well, I mean, like, and this is an interesting thing, because the lowest weight I have ever been before was 14.5 stone. Right. Which is, I don't know, I off the top of my head, I don't know how many pounds that is. But so, and this is where I was trying to ask my endocrinologist before, is it possible that is my set point, 14.5 stone?
Yeah.
Or, like, is it possible that the set point can change and all this kind of stuff? And they didn't have a clear answer for me. So I don't know. Now, again, just to call out here, I am not aiming to get to 14.5 stone. I still don't have a number in my head. I will have a ballpark kind of probably very loose idea, but I would say that like 1.5 to 2 stone ish is the max more that I will be looking to lose on my journey before I then flick into, right, I need to change my approach now for maintenance.
Yes.
And again, as you know, and as we touched on last week, that like 1.5 or whatever, that could take me the rest of the year, Belinda.
Yeah.
You don't know. And particularly with the way my journey has been, like,
it took me, Paddy, a whole year to lose 2.5 stone.
Yeah. Do you want to know what my average losses have been since I started, month on month?
Yeah, go on then. The average.
Sorry, not the average, actually. No, the actual loss, month on month.
Yeah, go on.
So, month 1, I lost just over a stone. Month 2, it was 10.5 pounds. Month 3 was about 16. The next month was about 8. The next month 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 6. The next month 6. The next month I went up over 10 pounds. That was month of surgery. And then the recent one,
Dropped.
kind of dropped kind of since then. So like there has been, but the thing that I need to stress in there is, first of all, that's not normal. That is not normal, those
No.
losses. My losses are abnormal. Okay. They're
Yeah.
not what people should expect when
Or
they're on this
aspire
journey.
to.
No, absolutely not.
Yeah.
100%.
And the reason we're saying that is because there are three types of people within the within taking medication for weight loss. There's people who it doesn't affect at all, who has no what's the word I'm looking for, Paddy?
So you'll have people that can be a fast responder, which
Yeah,
is a
like
small
you.
minority. You'll have people that will be, say, a slower, a
Yeah,
moderate responder.
like myself.
Yeah, and then you might have people that just don't respond as well.
Yeah, but you're a super responder.
Well, I'd say I was a fast responder.
I would,
too, so.
yeah, I would
would.
think so.
I would say that.
Because it's not average. It's not even near
No.
a fast loss.
And and like the thing is that I would say is, like, say for example, this past week, I have lost like, I don't know, 4 pounds or something like that, which has got me to here. But in the previous weeks, I've been pretty much staying the same or just going up and down the 1 pound. And that's the way my journey seems to go now, is that I could have 5-6 weeks where I stall or go back up a little bit. And then suddenly I'll have a week or 10 days where boom, I'll just drop
Bang.
something.
Yeah.
And that's the way it's been for a long period of time for me, maybe since late last year.
Yeah, see, I don't do that. I don't weigh myself anymore. I just weigh myself in the gym every,
brilliant.
I don't know, 9 weeks or something. And like, I tried to stay away from the weighing scales as much as I could because it was such a trigger for me. And I stay away from it now because it doesn't affect me. I don't.
Yeah.
It's an inanimate object on the floor. I worked through that with my health coach that I had, Nikki, and it took a long time, and that's what I try and tell people when they start out, don't put all of your worth into those objects.
100%. And I will say this time and time again, I don't care what number that shows on the scale. It's irrelevant to me. It is
You just like charts.
It is a data point. It is literally just a data point, and some people struggle to understand that. But like, I don't care about the number. It's just informing me, okay, how's my journey going at the moment. It's not like, oh my god, I'm up a pound, or oh my god, it's not that.
Doesn't matter.
But the 100 pounds thing is a thing.
It's huge.
So like, I don't know how. Like I've been thinking about this for more recently over the past maybe 2 months, when I've kind of thinking, okay, I'm getting near that kind of place, or 3 months actually, or whatever it was. And what kind of content do I want to put out? Because I've talked about this so many times over the past and stuff like that about wanting to lose 100 pounds. So it's fairly momentous for me. The next and the only other milestone, and I touched on this in last week's podcast, is the velvet jacket. So the velvet, you can't see it, but the velvet jacket is literally behind me. It hangs in this room the whole time on display. So every time I walk into
Oh my god,
this
is
room,
that not your real background, Paddy?
No. This is fake because the room is messy, although I did start tidying it because my sister's coming to stay in my house when I'm
Well,
away.
you can't beat my
No,
background.
you're super background. But anyway, so that is my update for this week, Belinda. So it is, which I'm absolutely delighted to share with people, and such a massive thing to finally achieve.
Congratulations again. I'm so proud of you.
Thank you. But so this week, Belinda, who are we talking to?
This week we have Dr. Mick Crotty on our podcast.
Oh God, I just like fanboy.
We're just so delighted.
And
delighted.
You're about to hear me fanboying hard at the start of this interview.
It's actually quite embarrassing.
It is, but also we do, on the back of that, I do then embarrass Belinda as well, just to make sure that it's shared embarrassment based on other stuff. So we really hope that you enjoy this podcast. Dr. Mick Crotty is somebody that we are huge fans of, that we love his advocacy, the work he does, and how consistent he has been with that advocacy as well.
Yeah.
And the work that he does at his clinic, which is My Best Weight. And again, we have zero affiliation with My Best Weight whatsoever. We've not even been patients of theirs or anything whatsoever like that.
Yeah.
But like over, the time watching them and showing the content they put out and the way they position things, really like the work that they do. But anyway, so folks, sit back, relax, and enjoy the conversation with Dr. Mick Crotty. We are delighted to be joined this week by Dr. Mick Crotty. I am going to jump straight in, and what we've done to our guests before, Mick, is what is your elevator pitch about who you are and what you do?
Elevator pitch. Oh God, I'm Mick Crotty. I'm a GP by training, and for the last 10 years, I have specialised in the treatment of obesity, particularly, I suppose, community-based medical weight management will be the kind of fancy way of looking at it. Realistically, I talk to people each and every day about how their life might or might not be affected by weight, and talk to them about treatment options. And I have a few other hats that I wear as well. I'm a dad, I'm a husband, I'm an amateur cook and baker, and a few other things. But that's kind of me in a nutshell.
Did I see hashtag new boy band as well?
Oh yeah. I'm thinking myself and Professor Carl LaRue and Josh Percival. We're half thinking of setting up a boy band. I don't think we'll be very successful. It might be a certain demographic we're kind of pitching to, but
but they're there. They're there.
Well, actually, you know, talking about demographics that are into things, what you didn't hear before you joined into this recording, we were talking about how you were on a previous podcast. Belinda's going to kill me. Belinda, what we were saying was your prep before Mick hopped into that.
There was three girls. Yeah, there was us. There was myself, Kim, Kath, and Bear, Kat's husband, or Kim's husband, and the three girls. We were sitting here putting on lipstick before you came on because Paddy brushed his hair before this one.
But on this side, I'm busy barricading the door so dogs and children can't come in. So it's kind of preparation is key.
Yeah.
But, you know, one of the things I have to say, and I don't know if I've said this to Belinda before, but myself and some of my friends have been for many years big fans of Dr. Mick Crotty because I would say going back, the first time I ever heard you talk would maybe have been, I'm going to say maybe 3-ish years ago, talking about obesity. And you were the first medical professional ever that made me feel like I wasn't doing something wrong and that I wasn't a failure, and that there was the potential that there was something more at play in relation to the last 30 odd years of obesity that I had been kind of living with. And you were the first person that was able to, that said words that resonated with me, that made me feel more human about my weight. And that was massive. And I'd say nearly emotional when I was listening. I remember I was listening to the car, the conversation you were having one day. And it just blew my mind. So from the get-go, like I'm fanboying hugely because that conversation you had such a profound impact on my, I guess, mental awareness about myself and about the years of living with obesity and other people around me that heard that conversation as well. So just from the get-go, just say that the words you speak and have spoken over the years have had a huge impact on people.
Huge.
Thanks very much. I suppose I say the same thing over and over again in the same way, and I say the same thing in clinic when I'm seeing patients. As if anybody gives me any kind of a platform, I say exactly the same thing. So I know what I've said because I say it over and over again. But for me, I think the key to trying to change the narrative in society and change how we kind of treat obesity is to share an understanding with people. And it's interesting, people who live with obesity, they get it straight away. Because when you understand the biology, when you understand how our body regulates weight, it explains why we have lost weight and regained it. It explains us why we feel hungrier when you're on a diet. It explains why we have all lost huge amounts of weight and it comes back over time, not because we run out of willpower motivation, because of biology. So I think really for me that's the key is sharing and understanding with people. And actually, it's probably easier to share an understanding with people who have the lived experience of it. Talking to sometimes other healthcare professionals who don't have obesity or don't live with obesity can be more challenging because people don't get it as much. And that's where the challenge is. So it's really easy to talk to people with obesity
who can relate.
They get it straight away.
Yeah. And it's profound. It is profound when people hear that for the first time. As Paddy said, having lived with it for 3 decades, you know, so yeah.
No. Definitely. So we touched on a boy band there a moment ago, but I'm going to take that back a step in relation to where that kind of formed from. So one of the areas of your life is My Best Weight, and I'd love to know a bit more about what is My Best Weight, or what is the mission of My Best Weight, or yeah, what's the purpose of it?
Yeah, so I suppose I was a GP in Ireland up until about 2014, working regular general practice. And myself and my wife then decided we'd go on a bit of an adventure. We moved to Canada. We spent 5 years living in Edmonton in Canada. And at that stage, I had no particular interest or knowledge of obesity because I didn't get the understanding in college or in my GP training. I thought about obesity the same way as many people in society think about it. And then moved to Canada and started, unbeknownst to me, Obesity Canada was kind of centered in Edmonton. So one of the most profound kind of medical education centers for obesity. Ended up going to a few talks and was absolutely flabbergasted by hearing kind of these experts talking about obesity in a way that I understood and helped me understand. Because again, I've had challenges with weight my whole life, and I understood it, and it actually made sense. And I was flabbergasted as to why I had never heard this before in college. Now I was pretty good for going, but I didn't think I missed that day in lectures when they talked about it. So to hear about it kind of just by accident almost while I was there was profound. And then I got more and more interested and started educating myself and meeting with different experts, going to conferences, doing different kind of training to kind of upskill, and then started seeing patients and treating patients. And eventually, after 5 years, I was told we were going back to Ireland, and I generally do what my wife tells me to do. So I said, okay, well, how am I going to make this work? I had actually developed a very nice obesity service in the general practice I was in Canada. So I'm going to come home now, and how will I do it? And to me, at that stage, I suppose it wasn't something that was done, and I checked, and there wasn't any clinics in Ireland. So I started reaching out to people, and I had met Professor Carl LaRue at a couple of conferences, and I knew he was kind of world-renowned obesity expert, and a bit like a lot of things in Ireland, probably underappreciated in his own country, but internationally is this kind of superstar in obesity. So we started having the chats and very quickly realized we were very much aligned in how we think about obesity, how we treat obesity, how we approach kind of management. So we said, look, well, why don't we set up a service ourselves? That's something that doesn't exist, at the moment. So
exciting then. That's very exciting.
Yeah, we started off very small, and we started off kind of seeing small numbers of patients, and I think mostly kind of it was word of mouth that it started spreading, and gradually then we added extra services. So we added a dietitian, exercise specialist, we refer out to psychologists, we added admin staff, and just kind of gradually we're still very much a kind of like a family type small operation. We're not trying to scale things and
rule the world
into this kind of multinational or anything. We're just looking to kind of treat people the best way we can. And we've added some more doctors, which is fantastic. And I suppose it happened to coincide then with a huge, I don't want to say revolution, it's a bit of a strong word, but with a much bigger awareness of new treatments becoming available, much more conversation. And we were, I suppose, doing this, and I suppose in my view, before many other people were kind of doing it and talking about these things, we're very comfortable. But it's really kind of gone from there. So I think it was about 2020, 2021 that we kind of started very small, and it's kind of grown over the last 4 or 5 years.
What's the difference between coming to you in 2020 and coming to you in 2025 with this big, revolution of all of the GLP-1 meds?
Yeah, to be honest, I still have the same chats with people. So when somebody comes to me, what I'm interested in is I want to listen to them. I want to listen to what's been happening for them, what's their story. Because I'm a bit old fashioned. We get people to fill out these kind of 12-page questionnaires that are really detailed, but there's actually no replacement for listening to people and chatting to people. So hearing, for me, it's understanding what has been happening for them. And then I suppose, mostly I'm interested in if or how excess weight is affecting somebody. Does it affect them medically, physically, psychologically? I don't really care what somebody weighs. I couldn't give a tuppence about what somebody's body mass index is. I want to know if their health is affected, because I might meet one person whose weight is here and their health is not affected. I may meet somebody else whose weight is exactly the same. There's every complication that can go with it. So, we can't make assumptions about people's health, about their lifestyle, about anything based on size or weight. We need to talk to them. And it's interesting, most people who come and see me, they're not on the surface particularly concerned about their HbA1c, their systolic blood pressure, their, these metabolic markers. They're concerned about their movement, their mobility,
longevity
for kids and grandkids.
Yeah.
They're concerned about, how they feel in their own body, energy levels, kind of very practical stuff.
And their mental health.
Because, when you're treating somebody, that's what you're treating. You're treating their health and well-being. You're not treating them to get them to a certain number. Because when they come in, I don't care what they weigh. When they're going out, I don't care what they weigh. I care about how they feel, how their health is, and how they're experiencing things. So
that's just so refreshing to hear, though. That's why we wanted to talk to you about My Best Weight, because that's what people need, isn't it?
And it's a challenge, because I think people come in, they want to lose weight, and I know they want to lose weight. And again, there's nothing wrong with that. Like, if that's their perspective and goal on things, then that's really fine. I'm very health focused, and I focus on health. Now, you will often find that significant weight change is associated with significant health gain. But if we're chasing a certain number, we probably will never, none of us will probably ever see the number we want to see. Yeah. None of us may ever be the size we want to be. We may or may not be the size we need to be, but we can be healthier, we can be more functional, we can be more active. Yeah. I suppose myself and Carl, very much like I say to people every day, I will not make you thin, and I will not make you happy. Because that's not what's going to happen. We can make you healthier. And that's not to say you're not healthy starting, but we can make you healthier. We can make you more functional. We can give you more quality of life. And what people decide to do with that function and quality of life, that's down to them, how they use that.
And so if I was, say if there's someone listening and they're trying to figure out what kind of path they are going to take for looking for extra support where they are right now, what does that kind of, I guess, process looks like in terms of, I'm assuming somebody sends an email or gets in contact with you. How do you then determine what is the right treatment path to prescribe for them in terms of if it's nutrition or movement, or is the case that all of that you have to take it all, or is it more bespoke and kind of ad hoc based on the person? Or I'd love to know a little bit more about the kind of patient journey once they contact you.
Yeah, I'm very thick and simple. And the approach I take to obesity care, weight management, is the exact same way as I would treat blood pressure, cholesterol, diabetes, depression, any other medical issue. So somebody comes in and we listen to them, we listen to their story, we do an assessment of their health and their background and different things, and what's going on for them and what's important to them. And then really for me, it's to talk about all the treatment options that are available, and that's nutrition options, life interventions, sleep, stress, patterns of eating, behavioral strategies. It's to talk about medication options that might or might not be applicable. It's to talk about surgical options. Yeah. And, for me, it's about finding the right treatment for the right person at the right time. Something might be a fabulous medical treatment. It might be the best medical treatment available, but it might be right for that individual, depending on where they are in their life, what they can afford, and what their perspective on things are. So really, my job is to give people information, and it's up to them. Like, people are smart. If you give them enough information, they'll make the right choice for themselves. Yeah. And really then it's a case of saying, look, well, the approach we're taking to this is the same as we would to hypertension. Let's choose somewhere to start. Let's treat you. Let's see how you get on. Let's change the plan depending on how you respond. And likelihood in 5 years' time, we'll be talking totally different, because the evidence might be different, what's available might be different. Again, for me, like many people who come to me might end up having bariatric surgery, and that's brilliant. I, again, no more than, I don't care about weight. My job is not to give somebody medication. My job is to give them information and then to help them with the decision-making process to see if that's right for them. But people need accurate information. They need to know what to expect. They need to know the costs. They need to know how long they will take this for. They need to know the potential risks and benefits, and then decide, is it right for them? Yeah. And a lot of people would kind of leave with information and say, okay, look, I just want to process that, because I suppose increasingly it's not the first time people are hearing these things. People are more educated when they come in to see
Coming
us
in,
because
yeah.
they've listened to yourselves and they've listened to, videos on our website. They've listened to various podcasts,
And
to
there's
get
books out there
information.
about it now that has never been out before, and yeah.
Exactly. So they're coming armed with more information. I suppose I would commonly hear people say, I've done everything in the past, and what they might mean is they've done every diet that there is and they've lost weight. Maybe they have never had supported nutritional therapy, with a dietitian. Maybe they certainly probably or may or may not have had medication. They may or may not have had surgery. And really, I suppose helping people understand we're not curing a problem, we are treating a problem. This is going to be a lifelong treatment. Even if somebody's weight comes from here down to what might be considered, and I hate the word normal, but they come down to a body mass index within a normal range, that person still has the chronic disease of obesity. They're just well treated. So again, that person over the course of time is going to need different supports.
Yeah. And
obviously, when we were planning the service, there's lots of different ways you can kind of go at this, and you can have packages of care, and you can have this, that, and the other. You can have, here's the all singing, all dancing. For me, everybody's journey is a bit different, and depending on what somebody has done in the past, depending on what they are, like again, if I meet somebody and they're a trained personal trainer, and they have done degrees in nutrition, they're a dietitian, maybe that person doesn't need to see the dietitian. Maybe they need the medication, treat the biology. Maybe you can have all the knowledge, but actually applying that day to day is challenging. So you need support and kind of help over time. So to me, it's not about saying you have to have this, that, and the other. It's a case of saying this is what's available. Yeah. What do you feel will benefit you? Most people who come to see me, they come to see me probably for medications. They might consider medication, and then we're kind of saying, okay, well, how is this going? How is that going? Would you benefit from this help or that help? And
yeah, and it's all really emotional, isn't it, for people, for your clients that come into you, for your patients that come into you, because being obese and living with obesity for generations or decades is an emotional thing. And I'm just wondering, what's like the most emotionally memorable thing for you, having had this business for how many years did you say? 6 years?
4 or 5, I think we're going now.
Right.
I make everybody cry. Yep. It's my talent in life, from patients I see to my wife to my kids. Everybody cries when they meet me. So we dig up the tissues, and it's sometimes tears of remembering traumatic events in the past, particularly as it relates to weight, comments from people. The amount of people I meet who bring up, getting their communion dress, or a teacher in primary school, or a comment from a family member. It might be a thing, in talking about how weight is affecting them. They might be talking about the things that they're restricted in doing, or, their life being on hold. Well, I'll start my life when I get to a certain weight. It might be, tears of joy that they're kind of saying, actually, for the first time now, I understand why my experience has been my experience. And
tears of hope.
Yeah. And actually on that side, it might be that, many people that I meet, they don't start the medications perhaps because they're afraid that it's not going to work, because they feel in their own head, I have, and their word, failed everything. And this is another thing I can fail. Whereas to me, like, nobody failed an intervention. If somebody doesn't respond, it's not the right intervention for that person.
For them. So, yeah.
There's a lot of what you've said there resonates with me. I'm a personal trainer from like years ago, and I had lost so back in like 2011 I was, I don't know, like 21 stone or something like that, and I went on, and we're going to loop back to this in a second, but I went on The Biggest Loser, the TV show, when I was over in the UK living there, and I lost, I think it was 6.5 stone or something. At that stage I thought, sure, I'm fixed now, the weight's gone, fantastic. Went and qualified as a personal trainer, and I would say within 18 months, I'd say at least 50% more of the weight that I had lost was back on, maybe more actually. And I stopped doing personal training purely because of that, such a strong feeling of being a failure. And I just could not figure out why I kept failing at this. And I went through some therapy then with a CBT therapist in Dublin, and we looked at kind of the relationship with food and stuff like that. And that was a big help in relation to understanding some of the behaviours and triggers and how I was responding with food, and that was fantastic. For one part off my relationship with food and things. But yeah, a lot of what you're saying there is definitely resonating.
Yeah, and for me as well. And
Like,
you, Dr. Crotty, you talk about the different methods that you can offer people. Have you ever had any of your patients like push back and disagree with you, or?
Absolutely, yeah. And again, I suppose I'm long enough in the tooth now to kind of come at this. It's not my job to try and convince somebody to do X, Y, and Z. I don't want to convince people. It's actually my blood pressure is too important. So, like, really, for me, it's a case of saying this is what the evidence says. It might or might not be what you want to hear. It might or might not align with kind of what you feel yourself. But this is what the evidence says when you look at the right evidence. This is how we approach things. That's not to say that how we do it is the only way to do it. It's not to say it's the right way to do it, but it works for me. And again, I suppose I spent years, talking to different people, listening to different healthcare professionals, how they approach this, how they talk about the words they use. And you start off by kind of parroting other people. And then you find your own voice and your own way of discussing this. And like I said, to me, it's very much like we have to share an understanding. So it's using the language people understand. It's talking about it in a way that people can kind of get. So it's not, to me, like, it's not a failed consultation if somebody doesn't leave on a medication. Not that I don't care, but like, that's not my job. My job is to say, look, this is the information that I'm going to provide you. These are the benefits. These are the risks. This is what's appropriate. This is what's not appropriate treatment. So if somebody comes to see me and they're not living with obesity, it's to say, look, these medications are not proven to be safe or effective, or kind of, in this context. They might be in years to come, but that's not where we're at the moment. And then it's for people to decide. And people will often leave and come back with further questions. I suppose people will self-select out. They'll come and see me because they know how I talk and they've seen me chatting and they'll come with certain things in mind. But I'll often stop and say, look, again, that's where the communication element is vital. If I'm kind of chatting to somebody and saying, no, this is not, they're not kind of reading off the same page as me, this is not what they're interested in, I'll stop and say, look, what should I be talking about here? Now, if somebody says, I don't want medication, I don't want surgery, happy days, great. That's easier for me because then I can say, look, this is, okay, let's talk about the treatments you're interested in. And I'll always want to plant a seed. Most people that come and see me don't want surgery. And I'll say, absolutely brilliant. I utterly respect that. It doesn't mean that surgery is not a fabulous treatment for somebody else. And in the future, it may be a great treatment for you. But, and I'm going to tell you, I'm a huge fan of surgery. Even though I'm a GP and a medical doctor, I think surgery is a fabulous, safe, effective, much maligned, misunderstood and stigmatized treatment. And I'll always plant those seeds. But my role is to talk to people about why they want to come and see me. And for some people, like, if I can simply, and I use that word kind of a little bit incorrectly, but if I can kind of help somebody understand their journey, if I can help them understand that internal bias and stigma that and the blame and shame they've lived with, like that's a successful encounter to me, and whether or not somebody goes on medication or not.
When you're thinking about, like, we spoke a lot there, but like about language and terminology and stuff like that, and obviously there's been a huge amount of talk about various measures or words to talk
describe.
About obesity. Yeah, and I'd love to know, when you're sitting there in your clinic, from your perspective, what do you see as being the most helpful or compassionate way to define obesity?
Yeah, I suppose I'm kind of the language police when it comes to obesity, and I will hear things in language that may not exist because I'm just so kind of down the rabbit hole on it. But for me, I think language is incredibly important for me. But equally, the person who comes and sees me, they may have a different understanding of language or different approach to language. So there are many words that I find very stigmatizing. Things like morbid obesity, I think we should just expunge from medical nomenclature. I don't talk about fat. I talk about the chronic disease of obesity, living with obesity. It doesn't define people. Person first language. But I'll often say to people, again, I probably use the word weight a lot because I think in Ireland it's probably a common one to talk about. And I might talk about excess weight, higher weight. We'll talk about weight affecting your health. But equally, some people don't like these words. A lot of people don't like the word obesity. They prefer the word fat, or they might identify with that. So again, it's different for everybody. I talk very similarly, and I have my way of kind of talking, and that's just normal for me now. And it's interesting when you go outside your own little bubble and silo and you hear other people talking, then you're kind of saying, actually, maybe they talk about that a bit better, and the way they explain that, that's clearer, and maybe I'll adopt a bit of that. And then other people are thinking, well, that needs to change. But language is important, and I suppose I say very similar things repeatedly over the course of the day. So even though, so somebody comes to see me, they're an individual, their journey is different. But again, in explaining things, I'll probably explain it very similarly. And one of the challenges is, I might have the same conversation multiple times in the day, but that person sitting in front of me, this is the first time they're seeing me. This is a huge, important, potentially event in their life. And to not underestimate the journey it has taken, the bravery, the fear, the anxiety, everything that they're going through to be there, even though it might be kind of the 10th person I'm seeing in the day, to still stay present in the room and acknowledge what that person has gone through to get there. And they have waited to see me and to be kind of there for the conversation. That's why at the end of the day, I'm just absolutely flat to the mat. Like, I'm just emotionally kind of drained and exhausted, because you're hearing people's stories, you're kind of sharing with them, and it's
God, that's
hugely
hard.
rewarding. It's hard, but it's an incredibly privileged position to be in. I'm very lucky. It's something I'm obviously kind of passionate about. If I was kind of clocking in and clocking out, it'd be much easier. But for me, it is important, and I suppose building that relationship with people, then I suppose it makes it easier then when you're kind of following up, because if I tend to, in our clinic, we tend to invest a lot in that first visit, in kind of, understanding things from people, kind of taking notes, kind of noting their history, making a plan. And the plan might be the same for 20 different people, but equally then we still need to kind of, have kind of the safeguards. We still need to have the understanding of things, and look, if this happens, get back onto us. You shouldn't experience that. We don't want you to have this, and just make sure people are kind of, we're all on the same page,
And so when you hear, I guess, on particularly probably social media, but also media in general or society, referring to the skinny jab, what emotions is that
stir up?
For you?
I in any media encounter I've had, I will always take the opportunity to kind of, say, these are not skinny jabs, quick fixes, not Hollywood's worst kept secret. Like, I say that in anybody I'm talking to, just to put it out there. But I have been quite active on social media and in media in the past, and that has led to good opportunities for me. It has also led to negative experiences for me as well. At times, I kind of pull back when there's, as I was saying kind of earlier, sometimes you kind of tend to be a little bit kind of Ozempic out. You're kind of a little bit kind of, there's just too much noise going on. But really, for me, what frustrates me most is kind of the inappropriate kind of use of these medications, the misrepresenting of these medications, treatments, will be a better way of saying it, and that kind of is challenging. Or when you, I think it's hard for anybody who's passionate and maybe educated in an area to hear somebody else talk about their area, maybe when they're not coming with the same kind of understanding of it.
Or empathy.
What they say, like empty vessels and the most noise and all that kind of stuff sometimes. So
this feels like a perfect moment to play a small clip. So you may have already heard or seen this clip, so it might be a surprise to you. But again,
it's not you. You're okay.
I'd love to get your medical or just even your personal reaction.
Reaction, yeah.
As I say, I was on The Biggest Loser in the UK. For me, it was actually a phenomenal experience being on it. But I would have been someone that grew up watching The Biggest Loser USA religiously, absolutely religiously, and somewhat in awe of seeing people having this opportunity, as I thought, to fix their lives via a TV show, and of the trainers that they got to use. And one of the people that I would have idolised would have been Gillian Michael. Would have been past tense Gillian Michaels. So she is one of the most
Most.
well-known, biggest platform health people, and I'll use that word very loosely. But anyway, this was, I'm saying you may have heard this already, but it's about 30 seconds or so, and I'd love to get your reaction afterwards.
It does slow the progression of chronic kidney disease, but that's in patients with chronic kidney disease. We all know that kidneys filter medication out of the body, so the bigger question is, how is it impacting the people that take it who don't have chronic kidney disease? On top of that, you can lose weight by eating less, using some common sense with your food choices, and moving more with no negative side effects, all of which do include pancreatitis, intestinal blockage, stomach paralysis, thyroid cancer, gallbladder issues, biliary disease, vision problems.
Yeah, this was on like one of the national kind of TV shows in America, and obviously, look, they'll be there to stir things. But, and again, that's probably a narrative you're probably used to hearing. But again, what does that kind of stir up for Dr. Mick Crotty when he hears it?
Yeah, it's not surprising. It's disappointing. It immediately lets me know she hasn't an absolute clue about obesity or the biology of obesity or evidence-based treatment for obesity. Conflating and there are side effects of any intervention. There are side effects of dieting. There are side effects of excessive exercise. There are side effects of meal replacement. There's side effects of medication. There's side effects of surgery. And that's where, people need to go in this with kind of informed consent, that they have the information to make a decision for themselves. But conflating or exaggerating kind of side effects and adverse effects, not understanding why these things happen, is kind of disappointing and scaremongering.
I think that's
it's a challenge about. Oh, sorry, go ahead.
No, I think that's one of her biggest things, though, isn't it? She's just scaremongering, and that's what she's just riding along on that.
This is what we hear kind of in the media very commonly. And it's often people who don't understand the treatments. And it's interesting, we see it, the most profound stigma that I see, I suppose there's two groups. And kind of one of the most profound stigma is from, maybe somebody from the fitness industry who themselves has never had any concerns about weight, who in their own personality, in their self-worth, in their whole, value of themselves is inbuilt this idea that I'm better because I don't have weight and I can manage my weight and I'm better than another person. And when we tell that person, actually, you know what? No, this is genetics, it's biology, it's life experience, it is complicated, it is chronic and progressive, it's not somebody's fault, it's not lack of willpower motivation, then it does something to that person on a visceral level, because you're essentially telling them you're not better than another person. So their self-worth takes a huge kind of blow. And then they will immediately kind of, backlash against these things. And like in science, we're constantly studying things, we're constantly coming up with hypotheses and changing our mind about things based on the evidence. But a lot of these people have an inability to look at these things kind of from a logical, rational, evidence-based way because, again, of bias and stigma that is instilled. Interestingly for me, I also see a huge stigma and bias from people who are perhaps in a group who have lost significant amounts of weight with diet and exercise and maintained it off long term. So there is 10%, 20% of people who lose weight with diet and exercise and maintain it long term. We don't know why. We don't know why that person can keep it off, why their set point has never perhaps been elevated, why they respond to diet and lifestyle interventions more strongly than another person. But those people sometimes I think come from a place where maybe they feel they've put in the hard yards, they've had the pain and misery, and there can't be, as they would say, an easy way out, a quick fix for this.
Yeah.
And like that's a ridiculous idea, because taking a medication for the rest of your life is not a quick fix for anything. Having bariatric surgery is not a quick fix for anything. and we don't think about other things like that.
But that is the narrative, isn't it? That's out there on social media and in the media, that this is a quick fix. And I think myself and Paddy are the living embodiment of this is not a quick fix. Like, I'm still working just as hard right now as I was for those 30 years when I couldn't shift the weight. Do you know what I mean? I still have to be careful of what I'm eating, get my protein in, go to the gym, go to Pilates, go swimming, go walking. I still am doing all of those things. It's just that biologically now I'm on the same playing field as everybody else, which I wasn't previously.
Yeah, it's interesting. A lot of those people wouldn't have the same thought process about depression, about diabetes, about hypertension, about other medical issues. But weight is held to a different standard. And again, it's society, it's diet culture, it is the cultural desire to be thin. It is kind of lots of different things. But people, it's hugely challenging. But again, you can't argue with, like, if I see a patient and they have a strong response to a treatment, like, you can't argue with that. Yeah. When you see, and really for me, it's seeing the improvement in health. People come back to me and I say, how are you getting on? First thing they'll tell me is how much weight they've lost.
Immediately.
And I'll say, okay, let's park that. Not that I don't care, but let's park that. What I want to know is, how are you feeling? Are you having any side effects? How is your health? Let's go back to those things that we identified on your first visit as to how your life is affected and how are they doing? How is your mobility? How is your pain? How is your sleep? How is your quality of life? How is the food noise? How are these things, because that's why we're treating you, not to get you to a certain size. And again, I know everybody is driven by different things, but having a kind of a health focus, that's the key. Because, like I said, we're not making people happy or skinny, we're making them healthier,
Yep, absolutely. And Dr. Crotty, is there anything about the popularity of GLP-1 medications now that's kind of worrying you?
I suppose in the misrepresenting is people understanding what they're for and what they're not for, and for me, like, obesity care is not transactional. That's what we started talking about. It's not kind of the commodity when somebody comes to see me is not a prescription. The commodity is, I suppose, maybe my experience, my knowledge, sharing that understanding their journey, making a plan. It's not all about the medication or the nutritional therapy or the surgical treatment. It's kind of having that understanding of what's going on, and then supporting that person if they're having side effects or having issues in the longer term. So when I see, let's say, somebody, and I know I might be on an island with this as far as, everybody has different approaches, but I suppose I get concerned if somebody gets a treatment without an adequate understanding of it, without adequate assessment, without knowing, okay, well, other than the medication, what else do I need to be doing for my health? What else do I need to be doing to make this, to reduce side effects and get the maximal benefits to health from it? If somebody doesn't have the understanding, they shouldn't become pregnant. If somebody doesn't have the understanding that this medication will need to be taken long term, and if it's not taken long term, like, we're just falling into the same pit we fell into with kind of restrictive diets kind of over years, if people are using these things short term. So access to these treatments, and that might be, whether people are getting them online, in different ways. So for me, it's the understanding is the huge part. The medication is kind of another part, but it's not the only part, So that terrifies me, and particularly when you see the side effects that people, and again, I say this everywhere I'm allowed to talk, but it is scary what people put up with when they're losing weight. It's terrifying. And they shouldn't, and there's no value in side effects. And we're treating people hopefully for the next 50 years of their life. It's not about getting weight as low as possible, as quick as possible. This should be different than dieting. If somebody's losing weight because of side effects, like that's just a negative. Like, that's not, there's no benefit to that.
And I think that's huge, isn't it? It's just about having the right person to talk to and getting the right medication and the right treatment, because out there now is just, it's not looking good, is it? Online.
Yeah, I think it's interesting. There's some people who, it doesn't matter if they get the medication from me or they get it from, somebody else in somewhere else, the medication will do the same thing for them biologically. But their journey, their quality of life, their side effects, their expectations, their health might vary. And again, like I said, it's not that I'm doing anything magic. Like this is not complicated medicine, but it's just having the time and having the experience to kind of have those chats.
Yes.
It's scary, or it's not scary. Not scary isn't the right word. Well, maybe a bit, but it's interesting. I would know, like from say chatting to Belinda as well. I would say on a weekly basis, I probably get somewhere between easily maybe 50 to 100 messages of people either asking about what do I do with ABC.
How do I work this pen?
How do I work the pen? I've had this side effect. What do I do? Is this normal? I'm looking at this. And my go-to answer every single time is, what has your doctor prescriber said? What
does your prescriber say? Yeah.
And 90% of the time people are like, oh, I haven't spoke to them yet. And that would be whether it is their local GP, whether it is online, whether it's another service they're using. And I haven't figured out yet why, if they've gone to the effort of actually getting the medication from, or a treatment from somewhere, that then they don't go back when they're having those side effects. They're
so common.
Yeah, it's massive, the amount.
Yeah, it's huge. It's huge. Yeah.
Yeah, there's lots of theories why that might be the case.
Yeah.
Like some people go in to their doctor and they'll be advocating for themselves, and the doctor might not want to prescribe the medication, for various different reasons, and they'll be given kind of the prescription, but again, not having those chats. People may not have a good line of communication. Again, people might be charged every time they're engaging with somebody. So
that's
financially,
there's
lots of different reasons, but it's challenging. Like this is care. This is people need support and
care and
we'll
treatment.
Often kind of get emails kind of trying to clarify things that I've said, and we welcome that because we don't want anybody sitting home. Like if you're not sure, I'm here and I can answer that. Yeah. Like I've heard. There is literally nothing I haven't been asked at this stage. I've heard it all before, and if I haven't heard about it, it hasn't. It hasn't.
So, nobody's thought of it yet.
Obviously, it's big for that person, but I've answered these questions before, and it's very easy. But again, and I think I said this when we chatted before, Belinda, about in the same way that people will tolerate side effects, they almost feel like they should be going through some sort of misery to lose weight. Like it's perverse that they will feel, well, I deserve this on some level because of that blame and shame they live with. And it's interesting. I'll use the word interesting as well, but maybe kind of scary that people feel that way, because it shouldn't be easy. Because again, we've been conditioned to think that this is misery.
And
we should be suffering. Yeah.
One thing I do say, or try to say as much as I can in terms of, like, say, even any of the videos I put out, like, this is my lived experience. Please never take your personal medical advice from a content creator, from somebody online, in that, because they're not your doctor. They're
certainly not on TikTok.
Question with something that they have experienced, your medical history, your current status, your other medications, all that kind of stuff is going to be really different, and that's why the medical professional that you're working with is the right person to try and re-engage with on those queries that you're having.
Yeah.
Absolutely, and again, I suppose people are desperate for treatment, they're desperate for information, and they're seeking it in lots of different ways. And if they can't get in the conventional way, they're going outside of that. And I sort of like I would meet a lot of people who are on various forums, and sometimes the information you might get, again, it might be very well intentioned, but it may be misguided, or again, it might be hearsay, it might be.
There's just so much out there.
About their lived experience, but their lived experience is different,
Yeah. So, Dr. Crotty, you're one of the few doctors in Ireland that's like openly treating obesity as a chronic condition. What kind of pushback, if any, have you gotten from your peers or like the wider system?
Makes it sound I'm one of the only openly obesity treating.
No, it's plural doctors.
I know exactly. Yeah, but it's funny. It's this. I think. I suppose it varies, but I think the narrative is changing slowly. I think things are improving, but I have driven across the country to give an educational talk to GPs, and experience some of the most challenging encounters professionally. Again, because of I suppose, like, frankly, aggressive, people challenging what I'm saying. And I have no problem being challenged, but you'll often get situations where somebody has willfully not listened to you for 40 minutes and then come back with the eat less, move more. I said, well, did you not see what I've just been chatting about for 40 minutes? Yeah. I suppose the common things would be, that I'm just money grabbing. I've got my own clinic and I'm just kind of, advertising that.
But yet you're out there trying to educate other GPs.
Yeah, and again, like a lot of us do a lot of stuff, whether it's with the Association for the Study of Obesity, with the ICPO, ECPO, kind of given time, cancelling clinics to go to different kind of events and stuff that you're not being reimbursed for. And like, again, I'm a self-employed business
Working
owner.
man,
Like, if I take a day off, I have no income. So again, like, a lot of us are doing these things, and that's not a bleeding heart kind of thing. But I'm just saying, it's like, if I was getting all the money under the table that the media suggests that I'm getting from pharma companies, I would be driving a much nicer car than I actually am driving, and going on nicer holidays. But that's the other one, is that, you're a shell for big pharma. You're just promoting these medications. And like, I will talk about nutrition therapies, I will talk about surgical therapies, I will talk about medications. Like, I'm not just kind of talking about medication. So it's very much kind of, shill for big pharma, just trying to make money out of this.
Right.
Is a lot of it. But again, we still pull the
Go
rope,
on.
and we still try and provide the education. And
Yeah. Even at this point, like, myself and Paddy have had people like message us and blatantly say to us, you're definitely working for Ozempic, for Novo Nordisk or something like that. It's like, I wish, my God, like, honestly, you've had that as well, haven't you, Paddy?
Even like anytime I do, like, say, a radio interview or the recent TV show with Catherine Thomas, got a good few messages after that, and he's obviously been
Name dropping
to go and do that kind of stuff, and it is gas. But the other thing that I find interesting about this is, like, there's nothing wrong. Like, as you say, you're a self-employed, like, you're a business owner. And that shouldn't also be stigmatized, the fact that you have a right to earn money from making a living. The same way the mechanic has a right to go and earn a living from fixing cars, or a personal trainer has a right to go and make a living from helping people with their health and fitness. And there does seem to be sometimes people being like, oh, they're making money off the fat people. Do you know, or that kind of thing. But,
like, ethically, I sleep very well at night. I have no concerns ethically, because, again, I know I'm providing evidence-based, non-judgmental, non-stigmatizing care to people who need it and deserve it. Again, none of these issues are brought up by patients of mine who I'm seeing. They're just glad to be kind of treated fairly. So then there is kind of an agenda, and anybody who puts their hand up and shouts about something is going to get kind of backlash, and I've come to expect it, and I have no problem. I am 100% open about my disclosures, conflict of interest. If I drive from Dublin to Middleton to give a talk, well, I mightn't be paying for my own petrol or my own dinner, and again, you're cancelling clinics to do it. So again, for me, it's a case of, people are making a living, but you're not. It's not. I do enough stuff gratis and kind of pro bono. This is not a money making exercise.
Yeah. So, do you, like, Dr. Crotty, do you think then medical education of doctors in Ireland are failing people with the disease of obesity? And, like, what would you change, if anything, about the education of GPs and doctors where obesity is concerned?
It's funny. Over the last year, I am now the clinical lead for obesity with the Irish College of General Practice. So education of GPs around obesity, that's my remit now. And we have just launched a blended learning kind of module for GPs and GP trainees. We've got a general practice update on obesity coming. I'm speaking at their annual conference kind of next week. I've written articles for the GP kind of monthly kind of medical education magazine.
Okay.
So there's a huge amount of stuff going on to educate people. I suppose the challenge is Many of us in medical training didn't get education in college. We didn't get it in our GP training. We haven't had the education, and now this is new kind of information to many people. So we're kind of starting kind of from a little bit of a not a blank slate, but also then we're kind of meeting it. I might be speaking to a GP and they're really keen to treat obesity, and what they kind of want to know is, how do I prescribe this medication? What are the side effects? I said, absolutely, that's really vitally important. But we also need to understand why obesity is a disease, why it is stigmatized, how to have a conversation with somebody about it, how to carry out an assessment, how to talk about nutrition therapy, how to talk about surgical therapy. So it's again
huge,
not
yeah.
just kind of the medication. So absolutely, I'll talk to them about how you use the medication, side effects, but I want to give them my bit as well about stigma and bias and biology and long-term treatment too. So
yeah. So you're rolling all of this out now. What will it take for this to be widely available to every GP in the country, or is it widely available already, and is it being picked up?
I suppose that the challenge is GPs are looking after everything, every disease area. And this week there might be an update on asthma, an update on COPD, an update on Crohn's disease, an update on this medication. There might be this specialist group that's looking for people to treat X, Y, and Z in general practice. And every week there are different kind of demands. And general practice is kind of at capacity, that people are working kind of above and beyond, kind of flat out in general practice, putting out fires, kind of, looking after sick people, trying to kind of provide the best care they can. And then I suppose this is another disease then that people are being asked to treat on top of all the work they're already doing. And there is often kind of, if somebody comes on and says, look, we want you to work 20% harder and we're not going to support you with that, then there is kind of sometimes a pushback. So people say, look, it's not my role. I haven't got capacity for it. In primary care and GPs are not resourced, so they don't get practice nurse time, access to kind of referral pathways. They don't get kind of resourcing for treating obesity the same way as they would for diabetes or hypertension. Because again, in the healthcare system, obesity is not considered in the same way. So again, this is kind of care that GPs are being asked to provide without actually getting the support, the referral pathways, without actually getting kind of remuneration for the extra work that they're doing. So that all needs to change as well in the healthcare system. So it's education. It is kind of resourcing, giving people the manpower, giving them the time, giving them the financial ability and the access to specialist care to treat this. But then it's also a case that, if you go into a practice in, let's say, inner city Dublin or Cork or any deprived area, these medications are not reimbursed. So oftentimes the people who need
them
treatment
the most
for their health are least able to access it. So that inverse care kind of law, that the people who need it most are least likely to be able to get it. So that's
that's a huge bone of contention, isn't it?
Yeah, one of the things like that bit about pricing and stuff like that as well. Like, I'm literally 25 minutes from the border here, and I, again, nearly every week, particularly from like Cork to in that part of the country, say with the treatment that I'm on, I can go across the border with my prescription, and like the dose I'm on will be £180 or something like that. If I just go and get that in a pharmacy down here, it's going to be probably the guts of like 500 and something. And like that disparity in the pricing is something that I don't know
crazy,
how we're going to or how the needle gets shifted on that, but it's at the moment, particularly over the last month, it's something that has been feedback that's coming, comments.
And I think that's probably because more and more people are on the medication, but that's nothing we'll be able to solve tonight.
You'll see the media reports of X treatment is now available, Y treatment is now available.
Yeah.
But then and people think, brilliant.
Yeah.
And then they go to the pharmacy and then this is the cost. And again, like, it is, to my mind, unfair. There's always going to be patients for me to treat.
Yeah.
But like, I have a big role in educating GPs to provide this care, in scaling care, because I can't see every person in the country, nor they mightn't want to see me. And again, like that, again, I work in private medicine, so people would have to pay to see me. So these are kind of challenges. So, we need to be upskilling healthcare professionals. We need to be, giving them the support, remuneration, resources that they need. We need to be supporting people to access treatment. And that's nutritional treatments, behavioral treatment, surgical treatments, not just kind of medication. And we need to be doing it across people's life. And that's a huge challenge, Like at the moment, we're only treating the tip of the iceberg.
Yeah. And if we think then, maybe shifted to think about what does treatment or supportive treatment look like specifically within the home and within the community? So I guess in your experience, how does that home environment influence a person's ability to be successful with their treatment?
Yeah, I think it's so I would say, as far as kind of the home environment, a lot of people I meet, their biggest barrier is biology, and once you treat the biology, a lot of the other things kind of fall into place.
Yeah.
So again, but like if I'm on a medication and I live with other people in my house, again, they need to have an understanding of what this medication is for me and the side effects I'm going to have and why I'm on it and how I'm using it. Unfortunately, not everybody communicates these things. We did a straw poll, it was last year, and we found 25% of people that saw me didn't tell anybody in the world that they were on these treatments. So I knew and their pharmacist knew, but nobody else knew. Their partner, their closest friends didn't know. A further 50% of people said that they would tell their closest friend or the partner, but nobody else. I think 10% said they would tell their wider friend group. And about 15% are you guys are kind of screaming it from the rooftops. So when you boil that down, 25% of people, 1 in 4 people are talking about being on these treatments. 3 out of 4 people are not talking about it. Again, because of the stigma. And that's a huge issue.
Two things on that. The first one is we did a similar thing, asking people a slightly different slant, but and it might feed into why they're not telling people, but about have you ever been made to feel shamed because of your weight by a friend or family member specifically? And I don't know if you have an idea for what number you might expect to hear, but the number that we got on this was, I think we got about, I don't know, from a sample pool of 400 or 500 people that actually replied to us. So a healthy enough amount of replies. And I think it was 91% of people replied back saying yes, that a friend or family member had shamed them or made them feel shame because of their weight.
I was going to say 90%.
Yeah. So we can understand why people aren't going around saying that they are actively taking these medications, because I think the first instance is fear of failure, and that's a huge thing when you do start these medications, I think.
And again, it's a bit like in healthcare, and I say the same things, but like no doctor goes to work to be an asshole. To try and be nasty to people. Like people are just living their lives and they're trying to do their best. And if they are sometimes blaming and shaming and stigmatizing people, it's often not coming from a place of nastiness. It's coming from that internal kind of intrinsic bias that people have, that they're not even aware that they're doing it in the first place. And again, a lot of family members might make comments, and it might be coming from a place of love and concern and caring, but how it comes across or how it is perceived or how it is delivered is kind of challenging. So again, that's where I think when somebody comes and sees me, I welcome their partner or family member coming in with them for the chats. Because number one, it saves them, when they leave there, try and get in the Spanish Inquisition. What did he say? Because shit, he said a lot.
Can't remember.
So it's easier when they've heard it. And again, people will actually kind of understand it kind of when they've heard it straight from the horse's mouth. So I kind of welcome that, because it often makes it easier. And the amount of times I will see somebody and then kind of, a couple of months later, I see their husband, I see their mother-in-law, I see their sister, I see their friend, kind of, word of mouth, but because it's often the wives will test it out first, and then the husband will be kind of railroaded in a few months later.
We had that in our house.
But again, like in families, again, it's interesting. A lot of people, one of the reasons they want treatment is because they don't want, let's say, their kids, growing up in a house where there is dieting and restriction and, where there is this constant kind of, issues with body image and kind of
talk
health.
of food
So, and again, many people I meet kind of have grown up, in an environment of diet culture and, going with their mom to Weight Watchers when at whatever age and starting. So, it starts very young. So a lot of people, that's the cycle they want to break because, we know excess weight and obesity is highly genetically linked. Somewhere between 40 and 70% of your risk of obesity is confirmed in your genes. So, if you have a parent who's living with obesity, their child is at higher risk. And you will see a lot of parents then, repeating some of the things that have happened to them in the past because they're so concerned that they see their child kind of having a similar experience. And it's heartbreaking for people. So I think within families, it's having the conversations, having the understanding, having the focus on health. Irrespective of our size, we should all be focusing on healthy eating. We should all be focused on movement and sleep and stress, regardless of what size we are. They may not be effective treatments for obesity for some people, but they're incredibly important for health. So,
And sorry, go on. Sorry.
No, I just said, I talk to everybody about nutrition and sleep and stress, not to lose weight, not to change, their body size, but to be healthier, to live longer and to feel better. That's a non-negotiable. So even if somebody's coming to see me and they want medication, I'm saying absolutely, but this is what we're also going to kind of look at because that's important. And many people have the tools to do it. And by treating their biology, you're just giving them the toolbox. So it's a case of, if we treat that biological element for many people, they have the knowledge, they have the information, and it's easier for them to apply it. But they still need to keep their eyes on the road.
Exactly.
It's not. There is no one treatment. There is lots of different treatments.
Yeah, and so how closely do you see mental health and obesity tied together? And do you think that we're doing enough to kind of treat them as linked conditions? Or what's your opinion on that?
Yeah, I think we know in somebody living with obesity, the rates of mental health issues are higher. Rates of depression, rates of anxiety are higher. We know the associations between ADHD, binge eating disorder. We know, there's lots of different kind of associations. And sometimes it's a case of, chicken and egg. Did I have a severe issue with my mental health? Went on a certain medication that caused weight gain.
Yeah.
It's interesting. Some people have an episode of severe depression. They will lose weight because their appetite disappears. They might have a similar episode 6 years later and their appetite increases. It's interesting. There's definitely a bi-directional relationship going on there. They are definitely linked. But again, I would never assume that, if I meet somebody and they're on my questionnaire or in their history, they report a history of depression, I wouldn't assume that that was anything to do with their weight. I would ask them, listen, does excess weight or obesity have any bearing on that, or is that a separate issue? And then I would say, no, that's separate. I'd say, okay. It's the case. I'm not assuming that the one thing is causing another. They might kind of, when they look at kind of patterns of change in weight over time, they might see certain things coinciding. So they might see, well, that happened and my weight changed, and this happened and my weight changed. And you kind of often see that, but irrespective of how I've gotten here, once I'm here, then that's where my thermostat is set.
Yeah.
This idea that we need to understand how people have gotten here, but the treatment is still the same once I'm here. So, but for mental health, people need support. And again, there are case reports of mental health kind of deteriorating in people on certain treatments. We know after bariatric surgery, on medication treatments, mental health changing. We know that if I'm treating somebody, their medical metabolic health may respond fantastically to, let's say, a pharmacotherapy or surgical treatment. Their physical functional health might improve significantly. Psychosocial health is a little bit more nuanced because, again, is it excess weight that's causing the issues with my body image, or is it diet culture, society? Is it the fatty cells themselves? It's probably not. It's how that's perceived in society. And you'll often see when somebody's in that kind of, I constantly am doing this all day with my hands, but when we treat somebody and they're in that dynamic phase, that response phase, and weight is changing, oh, happy out. Dr. Crotty is a genius. This is the greatest treatment, that kind of honeymoon period. And then, oh shit, what's happening now? This is slowing down. Oh, I'm starting to stabilize. My weight is not going down anymore. Oh, and I'm actually feeling a bit hungrier, a bit less satisfied. Some thoughts about food is coming back. Oh Christ, is this not working anymore? But yet my weight is not going back up. It's just staying at this level, but it's not where I want to be anymore. And my body image, and different things are kind of under pressure again. And again, I look in the mirror, I still see the same person as I saw when my weight was here. I don't see any difference. Other people might comment on a difference, but I don't see any difference, and I'm still not where I want to be. So again, I've failed, and all this kind of negative narrative comes back. So it in different, I suppose, increasingly we're seeing that in different phases of treatment, the goalposts move.
Yeah.
And I can attest to that, because I've been on this medication, this journey for over 2.5 years now, and I've met all of those. The stabilization, the moving again, the dropping of the weight, and the stabilization again, and you just have to keep going. And sometimes it's hard. It is hard to keep going, but
This is probably one of the commonest questions I get asked. And I'm going to use the dreaded word, the plateau. How do I break the plateau? How do I get past the plateau? And I've actually stopped using the word plateau in practice. I talk about stabilization and stable because just the negative connotations, it's kind of like plateau is not a negative word in English language.
But it is now.
When you're talking about weight, it's associated with this kind of negative connotation of I'm not where I want to be. So I don't talk about plateaus anymore. I talk about response and then stabilization. And, again, this idea that, is that where I'm going to be now? And so, well, if you continue on that dose of that treatment, yes. But if that's not where you need to be for your health or for your well-being, then you might need to change treatment. And I suppose where I will be versus where I want to be versus where I need to be, they're different places.
Very different places.
And that's where I suppose we and again, I suppose it's interesting. I talk about weight all day, but then I'm not actually bothered by weight, and yet weight is in the name of my clinic. And you're thinking, wow, you're talking about both sides of your arse at this stage. But for me, it's against we talk about this idea of best weight.
Yeah.
And I suppose that's where I will be when I'm living my healthiest life that I can enjoy and sustain.
Yeah, because it's funny.
It's not my lowest weight.
Yeah, I was with my own GP recently, and they were checking my weight, and like, oh, quite a significant change here. And I was like, yeah, I'm on my medication. I told the other doctor last time I was here, she'll be on fine. I was like, oh yeah. It's like, oh wow. And they're like, what weight is it you want to get to? And I was like, I don't have a number. I'm not working that way. I'm not bothered by the number. Like, I more so want to get my bloods done. I want to see what's my fitness level. I want to see kind of what is, how is kind of health for me. That's what my driver is, not whatever the scale is saying. So I was actually surprised then, because he came back with, and he was something like, yeah, like if you're to look at the BMI, that'd have you down as this. Like, don't go by that. At that stage, I think I was something like 117 kilos, whatever. He's like, look, at maybe pause and come in, and we'll reassess when you're like 105, 106, and see how do you feel then at that. And it felt like a very refreshing conversation, as opposed to, oh, you need to get to like 80 kilos or something to be healthy. It was like, oh, okay. He's seeing that at that weight, I would still be overweight, but was able to understand, but you could still be considerably healthier or healthy at that weight.
Yeah. Again, for me, like, there isn't a goal weight, there isn't a target weight, there isn't an ideal weight, because a person's weight is influenced by genetics, by biology, by life experience, by all the shit that's happened to them, by all the diets they've done, by all the positive and negative experiences and medication. Lots of different things influence where my weight will be. And it's not within our conscious control as much as we would like to think. So when we treat somebody, their response to treatment is not within their control. And that's hugely frustrating, because there is a degree of, although I keep my eyes on the road as far as nutrition and sleep and stress and the things that I can somewhat regulate, there is a little bit of a kind of closing my eyes and letting go on the steering wheel, because, when it comes to numbers, because I will be where I will be. Again, for most people I meet, that is not where they want to be.
Yeah.
Is it where they need to be? Again, health is relative. There is no healthy and unhealthy. It's a spectrum. So we know a 5% body weight change is good for your health. A 10% body weight change is more impactful for health. 15, 20%, even more. But again, if somebody's weight continues to go down, you can actually make their health worse. Muscle mass, bone density, disordered eating, and different things. So what I would talk about is, like, if I'm here with whatever intervention, whether that's nutritional intervention, medication intervention, surgical intervention, then that's where I am.
Yeah.
Can I get lower? Absolutely. But you may be stealing from health.
Yeah.
You may be stealing from sustainability. You may be stealing from your ability to enjoy life. And again, that's not going to be sustainable. So, and we often see it when somebody is kind of starting to reach that stable weight, not plateau weight, but stable weight. You'll see them leaning back towards maybe some of the strategies they used in the past, and the dieting, restricting. I'll just cut out carbs for a few weeks, or I'll just skip that meal and things, and their weight may go down further. But when that becomes unsustainable, even with the medication, and it's probably easier with the medication, but when it becomes unsustainable, they'll come back up to where they were before. So again, it's challenging, and I'm fascinated by, we ask everybody, and not because it changes our treatment, but we ask people, how much weight do they think they want to lose, or where would they like their weight to be? And it's fascinating to ask people, well, where did you come up with that number? Just out of
curiosity,
pure shits and giggles, where did you come up with that number? Where do you think they get the number from? As far as where they want to be.
I don't know, when they got married or when they were in school.
It's interesting. It's most commonly a weight they were at a time in their life when they were happy.
Right.
And again, kind of that might have been when they were 21 and they didn't have stresses. And they didn't have kids, and they didn't have this, that,
mortgages,
and the other.
and
exactly.
elderly
So again, but
parents.
they associate being happy with being that size.
Yeah.
They say, well, if I can get back to that size, then I'll be happy again. Like it's this.
I think it's funny as well that sometimes I feel other people do be disappointed when I answer, when they ask me, what's your goal weight? I'm like, I don't have one. And it almost bamboozles them. They're like, what you're trying to do?
What do you mean?
It's like, it's like, but you don't know what weight you want to be. It's like, yeah, but I'm not looking at it through the same lens you are. I don't have a goal weight as such,
And it's interesting, I suppose, on the medical side, like for most other chronic diseases, we treat to target. So we want somebody's systolic blood pressure to be a certain number. We want their HbA1c average blood sugar level to be a certain number. We want their cholesterol to be a certain number. And we treat because we have evidence to say that at that level, their risk of cardiovascular disease or whatever is minimized. And again, that's how we treat other diseases. I suppose with weight, it's not, because it's not within conscious control, and everybody's response to treatment is different. You can't kind of say, well, I want you to be X, Y, and Z. But there was the
BMI.
Looking at that.
BMI, that was, what everybody was looking to.
I suppose, and that's, again, some people, their goal weight might be a certain BMI. And that's one of the things that I'll be asked a lot, well, what do you do when somebody gets to BMI 25? Then do you stop the treatment? I go, no, like they're at 25 because they're on treatment. But to me, like the difference between 25, 26, 24, 27, like again, on an individual basis, it's going to be hugely different. And again, that doesn't tell us about distribution of weight, body composition. It doesn't tell us about health, really. It's
muscle mass,
it's
anything,
a surrogate marker.
Yeah.
It's a surrogate marker for excess fatty tissue, but it's not a direct indicator.
And so when we think about, say, some other disease that people might be living with, we know that quality of life or maybe success can be, or progress can be enhanced based on community support and how the community around them is maybe rallying around them or has measures in place to support them from that community space. I'd love to know, have you seen, I don't see that in Ireland yet. I see a small number of some kind of advocacy groups that are definitely out there, but in terms of, say, my local town or village or whatever, like, in terms of if I was to look for support with maybe the journey that I'm on or that, I would say there's very little, if anything, there. Have you seen any good or any attempts at community-based initiatives elsewhere that you think we could learn from in Ireland?
I suppose the answer is no. I haven't. Like, again, we kind of think all these magic things are happening in other countries, but they're dealing with the same issues we're dealing with. And we inherently think kind of that, well, in America or in Canada, they're doing things better. And whenever you come back from America and Canada, you're a great lad altogether. But again, they're dealing with the same challenges. I see a lot of people, for me, peer-to-peer support is hugely impactful. I can talk to them blue in the face about what somebody might expect to see with bariatric surgery, but it's not until they've talked to somebody who has that lived experience can they actually hear, the good, the bad, and the up and the downs of it. So I think that's huge. And again, the more people you can talk to, you'll realize that everybody's experience is different. I think a lot of people are probably getting that on social media. A lot of people are getting it from listening to influencers like yourselves, from listening to maybe doctors who put their head up and shout about things online. Forums, I think, are a big thing, but the challenge with forums is I think they sometimes start to lean into kind of a glorified Weight Watchers type, kind of, people giving unsolicited
Just
advice,
support and advice,
very much
yeah.
how much weight have you lost this week and how much weight have you lost
Yeah.
that week. And again, not through badness, just because that's the patterns that people have seen over the course of their life. So, I think peer support is vital. More people understanding this, your doctor understanding it, your family understanding it, you understanding it yourself. We do a lot of what I call breadcrumbing, as far as, on the first visit, I'm talking to somebody about when their weight stabilizes. And again, you're kind of dropping breadcrumbs. This is what you should expect. This is what you might navigate. So that when they do encounter it, it's not as much of a shock. They'll still kind of be kind of, up, down, or around when it does happen, but at least they have been forewarned about what's kind of coming.
What's coming,
so
yeah.
Understanding the journey is kind of vital, and that's for any area of health. Managing my own, our own expectations of what might happen is huge. And again, the more talking there can be, the better.
Yeah.
I suppose the challenge is, if I'm, let's say I'm doing this and people are listening to it, people will say, well, you're advertising this and you're advertising that and you're promoting this, you're promoting that. I'm not. I'm
same as we're
about,
not.
So again, these are the challenges, and that's what you're being accused of. But again, I think even myself and Carl LaRue are very much on the same page, and we've kind of said, we're not actually talking, and I suppose the language, we're not actually talking to skinny people. We're talking to people with obesity. That's who I'm talking to. So I don't really care what anybody else kind of thinks, because the people who
are listening,
I want to listening is somebody who's living with obesity, who needs support. So
that's all that matters.
Yeah, exactly.
Yeah.
If we think of the kind of the future then a little bit more, I guess where I look at, say, for the medication I'm on, if I look at
what's coming down the line.
Yeah, well, what's coming down the line, but also, I guess, to see, is there anything, not community driven, but just in general, in terms of the treatment of obesity. I would have looked a lot at the US, what's been happening there. Like, it's a whole other kettle of fish there, like with their compounds and all this other stuff that's happening. The UK have a slightly different market in terms of treatment or access to treatments and
availability.
And availability. Yeah, I'd love to know, is there anything that you think in general the US or the UK or even other countries have done well in terms of obesity care in itself that we should either do or avoid?
It's a loaded question.
That's our Paddy.
Yeah. I think for me, and again, my perspective, my opinion, my experience, I want this treated like other chronic diseases. I don't think we need to reinvent the wheel. I don't so how do we manage hypertension? You go into your GP, you're either having symptoms or you're not, it's picked up, it's diagnosed properly with the blood pressure monitor. Absolutely, of course, they talk about nutrition, they talk about salt, they talk about exercise, about stress, about sleep. And if your blood pressure is still high, then they put you on a tablet. And again, that doesn't mean that you don't still focus on all the kind of life interventions. And you're not seeing them every week. You're not seeing them every 2 weeks. You're not seeing them every once a month. You probably don't have a health coach and a dietitian and a physiotherapist and all these bells and whistles. Because for your blood pressure, we have effective treatments that kind of, fit with your life, well tolerated, and are good for your health.
Yeah.
And my hope is that in the future, it will be similar with obesity. At the moment, again, I suppose because medications can have side effects, because people's relationship with food is busted because of lifelong dieting, because most of us are kind of paralyzed when it comes to food, as far as, well, this guy's saying do this thing, that guy's saying do this thing, he's saying the fats are bad, he's saying the carbs are the devil. We're just so misinformed or disinformed or overwhelmed.
Overinformed.
It's hard to know where to start. So again, I suppose, if I see somebody in practice, with arthritis, and we've given them an injection in their knee, and we've done anti-inflammatories, well, they will benefit from physiotherapy. We send them off physiotherapy. So we use these services as they're needed, but there isn't a one size fits all. So I would like to see obesity treated the same way. Again, there's lots of people in the US. There's a little bit of a race to the bottom as far as how care is, and care is a very loose term, how treatment is provided. Like I see lots of people online by video consultation, and I'm happy that there's nothing I do in person that I don't do on a video. But again, I'm not sure everybody else is the same. So does everybody need an app? Do they need different things to kind of track? Again, I'm not sure. But if we're doing these things, we need to be studying them. We need to be researching them. We need to follow them up. We need to look at where are the pain points, where do people need support, and provide that support. But again, sometimes we're trying to apply a model. So I would see a lot of kind of eat less, move more that has been polished up, renamed, refurbished, and you stick a bit of GLP-1 on top of that. So it's
funny.
It's interesting.
I was having a conversation with someone yesterday. Actually, my own coach. I work with a strength coach once a week, and has a plan done for me for the other days as well. Even though I'm a personal trainer or qualified personal trainer myself, I still like to lean on someone that knows a lot more about this area than me, and he's the expert in it. But one of the conversations we were literally having yesterday was, I was saying, I guarantee you, within the next 12 months, you're going to see a surge from the high protein foods to like the GLP-1 booster foods or marketing. Because you can see it already in the US.
In the States.
One or two products starting to pop up with that kind of stuff. And
and also
the food industry will pivot.
Absolutely. It'll have to. I've also seen like PTs with absolutely massive platforms that would have, when the GLP-1 medication started becoming really popular, they would have gone against them completely. And now they're offering GLP-1 medication programs within their personal training programs. It's everyone's pivoting.
I sometimes, I'm by nature cynical and miserable. So I kind of sometimes have to park that and kind of say, okay, well, the scientific process is
a curmudgeon. Is that what they're called?
Seeing what works and changing what we do based on the science and evidence. That's what I'm fully of the opinion. In 10 years' time, what I'm doing I look back at presentations I gave 5 years ago. Jesus Christ, how did I say that? Like, that's absolutely shocking. Like what I was saying 5 years ago, and we will continue to change, and that's a good thing. And there will be people going at this genuinely, and then there will be people going at it kind of more disingenuously. Some people are in this for the long haul, some people are not. And again, I don't begrudge anybody, but all I can control is what I do, and what I do in practice, and what I would advise people to do. But again, like I would see people seeking care for obesity are vulnerable. They are desperate. And again, somebody may not be aware of kind of what's the difference between seeing me versus, a different provider that maybe has a different approach. And maybe the other provider might be much more aligned with what they need, or maybe they need to see me now and kind of, let's say kind of a year or 2 years down the line, they will see their GP for follow-up. And I welcome that. Like it's not me versus this guy or me versus that guy. It's about, we're all here to support the patient. And in the same way as I should be talking about what's the best treatment for them now, then I would say, look, would your GP, have you had a chat with your GP about this? Are they happy to kind of prescribe? And they might kind of head off, and I might not see them for a year or two. And then next thing they come back to me if they have a challenge or an issue. And like we see it a lot, when there was, let's say, shortages of medications and people stopped treatment, and then people were kind of, almost embarrassed, to come back because they've been off treatment and they'd regained weight. And I'll be kind of, high-fiving them as they come back in the door, saying, this is brilliant that you've come back to have these chats, because this is what we see with all chronic diseases, that adherence long-term, treatment long-term is very, very challenging. There's always going to be speed bumps. And I'll never give out to somebody for stopping a medication, because there's obviously a very obvious reason why they might have had to stop. It's a case of, well done you for kind of coming back and having that kind of courage to kind of, engage again.
And it does take courage, especially if in the obesity, if you have regained, it takes a lot of courage.
Belinda, will we move on to our final two questions? So
yes,
we've kind of we have kind of two wildcard questions for you, Mick, to finish up. So we do. So
Okay.
Belinda, I'll let you go with your one's a bit more sensible than mine. So I.
So, Dr. Crotty, let's say you were made Minister for Health for 48 hours. What's the first policy you'd push through for people living with obesity?
Jesus, give the fella the keys to the toy shop. Yeah, I think that's a tough one, to be honest. Yeah, I think I think that we should be creating regional hubs where people can access treatment, so that somebody could see, let's say, a GP who has a specialist interest in obesity medicine in Cork and Sligo and Limerick and Leitrim and Cavan, in the same way as we have these chronic disease hubs for hypertension, for diabetes. So I would love to see that kind of I suppose what's on a hub and spoke kind of situation where somebody might be referred from their GP to this kind of local specialist, be treated, go back to their GP, because I can't at the moment. I think it may be unrealistic to expect every GP in the country to be treating obesity just with the stress on the healthcare system. So aligning to other kind of chronic diseases, I would love for obesity to be included under chronic disease management program in general practice to get resourcing for people. I think it's unrealistic, if I'm honest, with the cost of treatments to make medication available to anybody and everybody. I don't think that from a healthcare economic point of view, and we saw that in the UK where it was going to bankrupt the NHS and they had to kind of pull back. So I think treatment for those who need it most for health is kind of vital. And again, I suppose I've done a lot in this. How many days did you give me as Minister for Health?
Just 48 hours. Calm down.
Yeah. Okay. All right. Yeah. We've. Well, I've probably sent a few emails about all that stuff, and then it's in a committee now somewhere being debated.
That was an awesome answer, though. Well done. Fantastic.
I think that's what I think. It's realistic.
Yeah.
I think it's also the easy answer would be everybody who kind of needs medication should get medication.
Yeah.
Everybody who needs surgery should get surgery. But again, that's not realistic, and actually, then it's it needs to be considered.
Yeah. Well done.
Dr. Mick Crotty is stranded on a desert island. What one meal do you bring with you, and what album or artist is on your playlist to keep you sane?
Oh Lord, that's a good one. What meal?
Now, this is the most important question of the night. So.
Yeah. I have yet to find a food I don't like. Okay. We thought we found one back in about 1996, but then we were mistaken. So I'd literally eat anything under the sun, but when I'm cooking here at home for the kids, my speciality is pizza, homemade pizza. Okay. So I bring my uni pizza oven to be very kind of fancy. That's my meal.
With pineapple or without pineapple?
Well, it depends who's eating.
No, you're totally on your own.
I throw it all out in bowls, and the kids throw onto the pizza whatever they want. And some of them are Hawaiian fans, but again, like I said, I haven't found a food I don't like.
Cool.
What am I listening to? So that really depends what kind of a mood I'm in, because if I'm annoyed, if I'm stressed, I listen to certain things. But my 5 years in Canada, I got myself an addiction to ice hockey. So my go-to is actually listening to kind of hockey podcasts. Is what I listen to. So it's a bit odd here because you have to stay up till 3 a.m. to watch.
I thought you were going to say Alanis Morissette there for a minute.
No,
or Justin Bieber.
I don't mind a bit of that. Actually, to be honest, do you know who I would, Tron? A bit of David Gray. David Gray and Mike Ladder. They're the real, the old, that's shown my age now.
Yeah,
but,
that's okay.
That's who I'd put on.
Yeah, that's good.
Love it.
Thank
Brilliant.
you so much for that.
Thanks.
And Dr. Crotty, it has been a pleasure. When we started the podcast last October as a half-baked idea to do something.
Oh, yeah.
And from those early days, we were like, we want to get Dr. Crotty on, we want to get Mick Crotty on, we want to get Mick Crotty.
You were the first, yeah. And we didn't think we could get you last season, so we thought we'll just wait now and we'll get a little tiny name for us and a tiny bit of the internet.
Yeah.
Oh Lord God. Yeah, I'm a legend in my own little household here, but not much further.
Oh, I don't know about that.
But I said I'll wrap up and just by saying again, kind of I guess what I started with. First of all, thank you so much for your time. But secondly, thank you for giving a man in his late 30s, a few years ago now, unfortunately, that belief that obesity wasn't his fault and that there was potentially a route forward and that there was people that believed me when I said I was making an effort. That still sticks with me. So on a personal level, thank you so much for that.
You're very kind to say it. But and again, like fair play, talking about your experiences, that you're leaving yourselves open, like a lot of people to negative, but I hope a lot of positive as well. Like it is very impactful for people to, like I said, that peer-to-peer support is vital, and
It's
there's not
crucial.
enough people talking about these things. So fair play and all that you do as well. But yeah, and I'm
Thanks
happy
very
to have
much.
the chat. The biggest problem with me is shutting me up. Or keeping me going, it's shutting me up. Is the
There was
problem.
3 of us here. It's okay. It's okay. Dr. Crotty, thanks so much. Thanks for coming on.
Not at all. Thank you.
Okay, folks. So hopefully you enjoyed that as much as we did. Like that was
That
one
was
of our,
amazing.
that was like one of our, I'd say like a bucket list interviews we wanted for the podcast when we started. You know.
Yeah. We have 2 kind of big bucket lists, and
Yeah.
Mick was one of them.
Yes.
Yeah.
Yes.
Yeah.
Yes. The other one.
Yeah. Is on its way.
It's on its
hopefully.
way. Yeah, we don't know if it's going to be this season or the next season. Well, we'll see.
Yeah.
But anyway,
Yeah.
So, and again, thank you so much to Dr. Crotty for being so generous with his time.
Yeah.
Like we kept
yeah.
him so long. Like
I know.
just
But sure, you couldn't shut us up. And listen, Mick is really, really generous with his time for us on Instagram as well.
Yeah,
you know, if we
he's-
ever have queries or anything,
he's brilliant.
He's so good. Yeah.
He's brilliant. And again, if you're not following Dr. Mick Crotty, it is mybestweight.ie. Is the handle. I'm just going to make sure that is the right one. Yeah, so mybestweight.ie on Instagram as well.
That's it.
And that's their website as well. You'll find him there. Belinda, anything else for this week before we finish up?
I think that's it. I don't think we could possibly talk any more than we've talked.
But like we've only been here a short period of time.
Love that for you.
Yeah, exactly. Yeah. Okie dokie. Well, Belinda, what do we want people to do if they're enjoying the podcast, by the way?
Oh, we want you to go on and follow us,
Follow us,
and if you could possibly write a review, that would be amazing.
It would be amazing. And as we always say as well, please don't take your medical advice from strangers on social media. Go to a doctor, a registered dietitian, a pharmacist, somebody like that, please, who is qualified and will try and help you on your journey. But from me, Paddy, i.e. at a dose of Paddy, and
Belinda at glp1.insights.
adios. We will talk to you again next week. Bye bye.